monitoring and management of immunosuppressants in your long case. Hello Dr. Humans, today I'm going to be giving you a structure to help you discuss monitoring and management of immunosuppressants in your long case. And I must admit that over the years this has been something that candidates have asked me again and again and they find tricky, and so it's high time that I made a video about this. Now here, I'm not going to go through every single drug and every single side effect because that would be incredibly dull. And for those of you who are enrolled in Rock Your Long Case, you'll know that the way that I teach this when it comes to transplant patients is using a puzzle. Way more fun than going through each of them bit by bit. But of course you can get this information from the literature, go through those side effects and know the side effects of immunosuppressants. That's going to stand you in good stead for your long case. But what I wanted to do here was to give you a framework for how to structure your answer to questions when it comes to monitoring and managing immunosuppressant medications. So, how do you discuss this like a pro? Ultimately, what I've created here is a little checklist in the form of an acronym. And that acronym is I'm Bosch. Now, I must admit that I was wandering around the electronic department of Harvey Norman the other day and I was looking for a stick vacuum. I actually bought a Samsung. As a cat owner, it's changed my life. But my point is that I just made this up, right? So you might have a better way to do this, but let's work with what we have. I'm going to show you this I'm Bosch acronym, and then I'm going to show you a little script so you can see how it all works when it's put into action. I'm Bosch stands for infection, malignancy, bones, obesity, sugars, cholesterol, and hypertension. Now, of course, bones and obesity are particularly relevant to patients who are on steroids. And diabetes can be caused by steroids, but also calcineurin inhibitors and mTOR inhibitors can contribute to this risk as well. So it's relevant to patients on all of those medications. And when it comes to those cardiovascular risk factors at large, both steroids and calcineurin inhibitors can cause hypertension and hyperlipidemia. So for transplant patients at large and patients who are on long-term steroids, this whole list is going to be relevant. But some patients are immunosuppressed with other agents, so you might have to pick and choose a little bit. So the structure I'm giving you really applies to transplant patients and people on long-term steroids, but if you're in your long case with someone who's immunosuppressed with other agents such as DMARDs or biologics or chemotherapy, you could definitely start with this, the infection and malignancy, but you're probably going to want to think carefully about what you say beyond that and sort of tailor your answer to the specific side effects of the medications that they're on. And some examples of specific toxicities are cytopenias. Bone marrow suppression can happen on mycophenolate, azathioprine, methotrexate, cyclophosphamide, and the mTOR inhibitors can cause cytopenias as well. And cytopenias can also be caused by antimicrobials such as Bactrim and valganciclovir. So don't forget those if your patient's on them as well. Now, Plaquenil or hydroxychloroquine, you're going to want to think about monitoring for retinal toxicity at regular intervals. And of course, it's usually relevant to measure someone's liver function and UECs to make sure that they don't develop any toxicities in the context of that. So for example, methotrexate can accumulate in renal impairment, and that can increase the toxicity of methotrexate, but methotrexate can also cause liver toxicity, and so you want to consider monitoring the UECs and LFTs where relevant as well as part of this answer. And so what I'm trying to say here is that I'm going to work through this I'm Bosch structure in just a text so you can use this when relevant, but I don't want you to stop thinking about the patient in front of you. It's a handy checklist to really think about whether this applies to your patient or not. Okay, with that said, let's see I'm Bosch in action. And for this, I'm going to use little Jenny. We saw Jenny before. Jenny is a renal transplant patient. She's on all the usual medications, tacrolimus, mycophenolate and prednisolone. So we're going to use Jenny as an example, and I'm going to talk through how I would manage her immunosuppressant complications. And what you'll see me do here is I'm going to be using some of the information that I've collected during my long case, including their vaccination status, any malignancy screening that Jenny's had, looking at the cardiovascular risk profile that I've collected as well. It might sound something like this. In terms of how I would manage Jenny's ongoing immunosuppressant complications, I'd broadly divide this into minimising infections, screening for malignancy, as well as attending to bone health and cardiovascular risk factors. With regards to minimising infection, I note that Jenny is up to date with all of her vaccinations. I would also be interested in reviewing any CMV and BK virus PCRs over time. In terms of malignancy screening, I note that Jenny has been engaging in population level screening and recently underwent FOB testing, and I'd be very interested to review those results. She's also undergone annual skin checks with no skin lesions of concern. However, I note that Jenny has not had a pap smear in quite some time, and I would like to encourage her to have this performed in the near future with her GP. In terms of her bone health, I'd be interested in reviewing Jenny's recent vitamin D, calcium and phosphate levels, as well as her most recent bone density scan. If this was to show osteoporosis, then I would like to consider anti-resorptive agents in Jenny, but of course I would encourage Jenny to have a dental assessment prior to commencement of any anti-resorptive therapies. And finally, with regards to her cardiovascular risk factors, Jenny's blood pressure is well controlled on her current medications, and I would continue to aim for a target blood pressure of 120 to 130 systolic in the longer term. I'd be interested to review her lipid studies as well as her HbA1c and glucose levels, and in addition I note that Jenny's BMI is in the overweight range, and it would be important to avoid further weight gain, and ideally I'd like to work with Jenny on a strategy to lose weight through diet and exercise in the coming months. So something like that, right? And I think what's important here is touching on those broad categories: the infections, vaccinations, the malignancy screening, including skin cancer screening, as well as bone health and cardiovascular risk factors. But the way to talk through this is to refer back to your patient as you do it, right? What do you know about the patient? What would you like to know about the patient that would help you to manage them? And what are you going to do with that information? So I think that approach would stand you in good stead in your long case, make you sound oh so professional. And honestly, it is what we do in clinical practice. So there you have it. I'm Bosch for the long case win. Now you might come up with something better, and if you do, please let us know in the comments below so we can share it with the entire group. Thank you so much for joining me, and if you would like to dive into more detail on the management of transplant patients, including all of those medication side effects, and in addition to that, how to manage diabetes, osteoporosis, obesity, heart failure, depression, rheumatology patients at large, then come along, join us for Rock Your Long Case. It's all in there. And otherwise, I'll see you again here in the next video. Bye!